You've survived and made it to part 2 of chapter 9. Let's keep going. We're in the circulatory system. Okay, remember we were talking about the different levels of the vascular system. We've already discussed large arteries and small arteries and arterioles. Now we're going to move on to the capillaries and the veins. So to review our capillary structure and function, these are going to be things that govern the capillary fluid exchange. So remember, our capillaries are a collection of very narrow branching blood vessels that are located between arterioles and venules. The capillary walls are a single endothelial cell thick with a small amount of a basement membrane. They are thin-walled and permeable, and that makes them specialized sites for our exchange of gas, nutrients, fluids, and waste, right? The rate of exchange is based upon the size, solubility, and the charge of the substances. Exchange is also affected by the charge, abundance, and size of the pores within the endothelial cells. Okay. The first thing we're going to talk about is the different types of permeability of the capillaries. Okay. The first one they talk about is here in A, which is the continuous capillaries, and they are the most abundant type, and they're found throughout all the tissue. These capillary walls have a continuous layer of endothelial cells, but possess small pores, or clefts, in between. And these pores allow for fluid exchange and water, electrolytes, and other small water-soluble molecules, so think glucose and amino acids. The pores, though, are too small to permit movement of plasma proteins, which remain then in the vessel and exert a force called colloid osmotic pressure. And that helps maintain and retain fluid within our capillary lumen. Capillaries in the intestine, kidneys, and endocrine organs typically have loose endothelial junctions that are called fenestrated capillaries, which are here. These fenestrated capillaries allow higher rates of fluid exchange, and they often have greater exchange of molecules such as the smaller proteins. The functions of the spleen, liver, and bone marrow, though, require passage of large proteins, so they will have an even greater gap in their cell wall. And we these here, and these have the sinusoids, which are modified capillaries with large gaps between them, and they have a discontinuous basement membrane, so they allow the passage of the large proteins and even cells across their capillary walls. The net fluid exchange across the capillary walls is influenced by the summation of the capillary and interstitial pressures. So on the inside and the outside of the capillary, both sides have hydrostatic pressure that push the water and the small dissolved molecules away from the source across the capillary walls. Both regions also have osmotic pressures created by proteins that have little ability to move across the capillary walls. So our colloid osmotic pressure pulls water and the small dissolved molecules towards the source across the capillary walls. And it's the balance of these pressures that establish the net movement then of the fluid and solutes across the walls. So the rate of transport can also be influenced by a filtration coefficient that is affected by the density and the properties of the filtration pores. So now we get into the weeds here with some more math, which we're not going to get too caught up in. The values for both capillary and interstitial hydrostatic pressure can vary widely depending on what tissue or organ area you're in. Okay, so in some cases, our interstitial hydrostatic pressure is negative, favoring filtration. For continuous capillaries, the average capillary hydrostatic pressure is different than the interstitial hydrostatic pressure. Thus, the net hydrostatic pressure gradient favors filtration. So it favors fluid movement outward across the wall. With all of that being said, what are we trying to say? Okay, is this. Fluid that moves is a protein-free ultrafiltrate of plasma in the continuous capillaries. The exception is our blood-brain barrier, where they have no pores and you have to have substances require a transporter to cross. The fenestrated capillaries allow greater rates of the water and solute to move as required for organ function, and they can promote permeability of small peptides and proteins. And then the discontinuous capillaries are the sinuses or the sinusoids, and these have the bigger gaps, and they have a discontinuous basement membrane, and this tends to be found in the liver and like bone marrow and the spleen. Also, they are found in highly vascular organs with low vascular resistance. Okay. Starling force is at play, where fluid movement across the capillary walls is governed by this force. Filtration is movement from blood to the tissues. Absorption is movement from the tissues into the blood. This depends on the capillary permeability in the surface area. The pushing force is our hydrostatic pressure, and the pulling force is our colloid osmotic or oncotic pressure, usually higher on the blood side. Normal filtration reabsorption along a typical capillary within the systemic circulation is shown here. The black arrows represent the magnitude and the direction of the fluid exchange. The pressure values are shown there in the millimeters of mercury. Okay. Hydrostatic pressures at the arteriolar and venular ends of the capillaries are shown. The yellow rectangle represents the pressures in the interstitium. Okay. The parentheses indicate the net filtration pressures at the arteriolar and the venular end of the capillary. So you can see here that the pressures change, and this is how it changes what comes across and how we exchange based on these pressures. Pretty straightforward. In the way of, we're just understanding that the oncotic and colloid pressures and the hydrostatic pressure are all the variables to determine how we exchange at the capillary level. The next, your book goes into the lymphatics. So interstitial fluid in the tissues arise from the capillary filtration, and this will form into the lymph and the lymph system that returns to the circulation via this lymphatic capillaries. These capillaries converge and feed into low-pressure lymphatic vessels with one-way valves that's going to facilitate lymph transport. Lymph vessels usually converge at lymph nodes that then filter fluid proteins and are very active in our immune processes. The lymph then proceeds back into the circulation, primarily through the subclavian vein. So we have blind-ended capillaries with permeable valves. They will collect the fluid and connect, like we said, with the one-way valves here. The lymph is propelled by the smooth muscle to the larger collecting system, which is also aided by skeletal muscle contraction and massage. So our legs, for example, as our skeletal muscles work and move, we're slowly also moving the lymphatics and getting that fluid to move with it. Okay. The normal flow is 2 to 4 liters per day through the lymphatic system. So, favor are conditions that are going to lead to excessive lymph flow and edema. When we have vasodilation of the arterioles or an increased arterial pressure, when we have greater push, so greater hydrostatic pressure, reaches the capillary, favoring filtration over reabsorption. So you're going to get the water to stay in the interstitium. So if we have high blood pressure, that can cause swelling. If we have localized inflammation, edema is local but not generalized, and we can get swelling. If we have venous obstruction, that's going to lead to excess lymph and edema. Again, you're going to have greater push at the capillary end, so you're going to filtrate more than you absorb back into the blood. So this is like thrombosis, pregnancy, right-sided heart failure, or just our age-associated venous hypertension. We can have hemodilution, so a decreased plasma oncotic pressure, so we have less pull, which again favors filtration, so the fluid stays into the interstitial tissue. This is like nephrotic syndrome, liver failure, or protein malnutrition. You can have congenital lymphedema. You can also have lymphatic obstruction by things like tumors, cancers, surgeries, infections, or post-trauma to the area. So conditions promoting reabsorption over filtration. So now these are conditions that are going to favor us bringing the fluid into the bloodstream and not staying in the tissue. So if we have arteriolar vasoconstriction, if we have a decreased plasma hydrostatic pressure, so we have less push. So now we're going to have more reabsorption versus filtration. An example would be that if we have a hemorrhage or we're hypovolemic, we're going to vasoconstrict to bring in more fluid within us, also into the vascular system. Autotransfusion is this phenomena, if you will, of the balance of the Starling forces, because now you're going to get reabsorption of the fluid along the length of the capillaries because of this change in the oncotic pressure. All right, moving on to disorders of the veins. When we're talking about the venous system, we have to remember these things. The vein structure has thinner walls, they're more compliant, they're easily deformed by volume or pressure. Our leg veins work against gravity, right? So we have to have these one-way valves to prevent retrograde flow. We have to have adequate muscles to be the muscle pump of the leg, which helps compress the vein, propelling the blood back up to the heart. So the legs are the most common site of venous disorders. Okay. You can have venous dysfunction from genetic influences. People can have varicose veins that run in the family. You can have venous dysfunction based on your employment, whether you sit or stand, etc. And then things like pregnancy and obesity can affect the venous dysfunction as well. This is showing us the leg vein anatomy. Under normal conditions, here, and then B, this is with venous hypertension. Venous drainage of the leg is through the deep and superficial veins that are connected by perforator veins. Remember, gravitational pull on the blood increases venous pressure. The highest venous pressures are at the feet and the ankles. Contractions of the leg muscles will propel and facilitate the emptying and reducing the venous pressure. With aging or primary venous disease, our superficial veins fail to empty and they become tortuous and dilated, and the flow from deep veins can reflux into superficial veins, worsening the pressures and the dilation and valve incompetence, and this will lead us to the varicose veins. Your book, or the PowerPoints kind of skip right over the DVT formation, which is a minor part in this book, but I do want you to read that section as well. Then it jumps into some of the pediatric considerations and talks a lot about the development of our circulatory system. So this is a nice review, and it's still important for us to know. So within the first 4 weeks of gestation, our early embryo has developed 2 sets of early blood vessels. We have hemangioblasts, and all of this goes through to how we develop the blood vessels. The developing blood vessels form the heart that begins beating in the 3rd week of gestation. Then we get the endothelial cell-formed tubes begin, and then we get our capillary networks to begin to form. So early life conditions that promote later metabolic dysfunction is what I wanted to talk about a little bit here. So there are indirect indications that prenatal and early childhood influence increase the risk of our metabolic dysregulation that could promote cardiovascular disease throughout adulthood. Okay. Maternal obesity during pregnancy has been associated with childhood being overweight and obesity in their offspring. Famine studies have shown that maternal starvation can result in glucose intolerance or hypertension. There's studies that demonstrate that low birth weight infants develop type 2 diabetes and coronary artery disease at greater rates than those with a normal birth weight. Fetal growth development, that's if you have intrauterine growth retardation or restriction, that will cause the low birth weight, etc., and increase your risk. It's also notable that babies born for just gestational age or who have macrosomia are similarly at risk for obesity and metabolic derangements. They think that the profile of insulin resistance, hyperglycemia, and hyperlipidemia will begin in childhood, and that will greatly increase as you grow old. I'm not going to go through and talk about all of these because this is pretty straightforward, just reading it in your book. The slides here give you a nice review. All right, gerontological considerations. Blood vessels are dynamic structures, and they are remodeled by complex pathways throughout the lifespan. Remodeling of our vascular system with aging influences structural and functional changes of nearly all other organ systems in the body, particularly the heart. There's 2 major changes that occur in the arteries with aging. We get increased arterial stiffness, which propagates throughout the vascular bed centrally to peripherally, which causes the endothelial dysfunction. So the stiffness and the endothelial dysfunction are 2 changes that we see with age. We also can see reduced capillary density, increased proximal aorta length and tortuosity, and increased rate of aneurysm development. Beautiful slide here. I love this one. That tells us the mechanisms here, the changes in the arterial wall that leads to the stiffness, and the hemodynamic consequences here. And these worsen with age. And this brings us around again to inflammaging. Endothelial dysfunction due to the greater oxidative stress with age causes this consequence. Systolic hypertension will have cardiac consequences due to the vascular stiffness, loss of the ability then to vasodilate, and predominance of the circulating vasoconstrictors over vasodilators. You're going to have greater aneurysm prevalence, and you're going to have a greater prevalence of vein disorders, specifically chronic venous insufficiency or venous ulcers. All right, summary, which is lovely. The systemic vascular system distributes output of the left heart to the body. The aorta and large arteries receive the systolic pressure and volume. They expand slightly and they convert potential to kinetic energy on return to their original size, which assists with the diastolic pressure and flow. Thick walls are protective against damage, but their delicate endothelial lining is subject to injury, which leads us to atherosclerosis and aneurysms. The arterioles are sites of narrowing and increased resistance to flow. Arteriole walls are rich in smooth muscles that regulate vessel diameter and vascular resistance, which is very prevalent in the controlling of our blood pressure. We have neural, endocrine, and humoral and local mediators that will alter the flow systemically or regionally. Norepinephrine from the sympathetic nerves is the major vasoconstrictor. It is the norepinephrine also that helps with tonic activity that supports the upright position. Endothelial nitric oxide is the major vasodilator with tonic activity that maintains normal blood pressure and normal organ blood flow. The capillaries are the sites of increased permeability and exchange of fluid and substances between the blood and our tissues. Capillary hydrostatic pressure promotes fluid movement out of the capillary walls through the pores, which is filtration. Capillary colloid osmotic pressure is the fluid attracting property of the plasma proteins, promotes movement into the capillaries from the tissue, which is pull, which is reabsorb. The imbalance of these forces can result from a lot of different things and will cause edema. The veins have thin walls but high compliance. They can hold 2/3 of our blood volume at a very low pressure. The veins are vulnerable to dilation and lengthening when subjected to increased volume and pressure. Reduced flow rates in the veins, particularly due to immobility, will promote thrombus formation, venous stasis, and venous hypertension. And that was a very short and sweet next section for you guys here. Also to point out a couple of things, we did briefly talk about the ABIs. Your book does go into, which I love, the bridge to clinical practice. I do think this is great for you guys to read and review, which is the principles of assessment. This is a teaser. Once you get past patho, pharm, and physical assessment, then you're going to move into this, where you're going to put together the history, the physical, the exam, the diagnostic testings, and the assessment. So this is beginning to show you what is to come and help begin to tie it in already with you. Okay. When you talk about some of the major drug classes, it's also kind of trying to put in your brain to associate what drugs we would be talking about, right? Like antihypertensives or antiplatelets or lipid-lowering agents. So they kind of all blend in. I really like that. I think it's helpful. Don't get caught up on memorizing anything of the bridge to clinical practice. Okay, that's not where the testing material is coming from. The key points at the end of your chapters are great. And if you are getting ready last minute to study for the test, rereading through key points will be very, very good review, in my opinion, as well. All right, thanks for holding on through chapter 9.